Down fracture.
Down fracture.
Down fracture.
Down fracture. Down fracture. We're talking jaws.
All opinions expressed in this podcast by the hosts and their guests are solely their own. This podcast is for informational and entertainment purposes only and does not constitute medical advice.
All right. Hello and welcome to another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast@gmail.com if you want to reach out to us. We also see some comments on YouTube and stuff through the email, which is helpful. We do take it into account. We don't always choose our episode every single time based off of that, but we keep a running list and we'll get to you. We pay attention. Dr. Michael Wasson here as usual with Dr. Sam Bobek. Sam, I've been meaning to ask you, is Sam short for something? Like, is it short for Samuel or like?
Yeah, Samuel. Yeah, you're Michael, aren't you?
Yeah.
All right.
I don't know if it's, what's that?
Did you just
wanted to know if it was
pop into your head now after however many years, 20 years?
Yeah. I know if it was short for like sandwich or something like that.
Yeah, no, Samuel. It's good to see you, dude. How's your weekend? Happy Father's Day, by the way.
Yeah, thanks. Had a good Father's Day. Did you have a good one? Do anything special, fun, exciting?
Watched some beach volleyball. I got a kid that plays that, and so that was pretty good. They had at the lunch break, they had the dads go out and serve, and I showed that serve who's boss. Like the middle-aged dudes serving in beach with their kids running around as healthy as they could look. That was, especially in Seattle, you can imagine all the white guys. It's crazy.
Yeah. Yep. So
like,
did you that was about all you did?
I served once and they said you gotta get out of here. We don't want to see that anymore. But that and just spend time with the family. So it was good.
Same. Yeah. We went and saw Toy Story 5.
Oh, nice.
Yeah, I would say it's probably one of my least favorite of the Toy Stories.
Yeah, I don't remember 3, 4. I didn't even
I don't
know
that I saw 3 or 4 either. But yeah,
Wait.
I didn't love it. But I got to spend time with the kids. They liked it. Whatever.
Well, so what are we talking about today? We have a guest, I think.
We do have a guest, and I think you're more familiar with her than I am. So do you want to give her a brief introduction, or Angie, do you want to introduce yourself? What do you want to do here?
I don't mind introducing. We have Angie Murphy with us. Angie, I met a long time ago when I was in North Carolina. She was in charge of stuff there. I'm not still entirely sure what that was, but like a manager or doing the AAAHC thing at that time. But she was a lovely person. You'll see as she talks to us, but later on, she came and helped me out in my clinic in terms of helping me get certified or helping us get certified with AAAHC certification. And she continues to help us out. So I've known her over the years. She's a very normal human being. She runs her own consulting firm. Is that the Murphy Healthcare Consultants? Because you've branched out into bigger and better things, right? So anyway, I appreciate Angie being here. Angie, did I miss some key things, or is that okay?
I think that's okay. Yeah, I think that's
Nice.
okay. I've spent most of my career in oral surgery, and I love the compliance aspect and just making sure that everything's going the way it should go. So it's kind of natural transition to helping practices get their accreditation.
So you were originally tasked with getting Meyer and Tucker to be compliant with AAAHC criteria.
Yes.
Is that your first task in compliance? Because that sounds like a hard task.
That was my first time working with accreditation standards, and
When did you start doing it?
in 1999 he started bringing jaw surgeons in the office, and then decided to pursue accreditation. And so we had a team initially of about 6 of us that tackled it, and we achieved the accreditation in 2002, and then it somehow magically fell onto my lap after that to maintain. So I kept that going for the practice until I left there I think I left in 2017. So I maintained it that entire time.
That's crazy. When did AAAHC become a thing for oral surgery? Was it about that time?
I think it was about that time. Yes.
Because there's some other early adopters, I think. And
Yeah.
now it seems to be picking up again in interest.
I think so. So, our practice manager at the time, he felt like some states were starting that path, like California and New York were starting to require it. And he just thought, you know what, let's go ahead and do it when it is, when it's optional for us instead of becoming mandatory. And it is 2026 in North Carolina. It is still not mandatory. Most states, it is still not mandatory. So they were way, way, way ahead of the game.
Got it. Do you just work with oral surgery clinics in terms of AAAHC, or do you work with plastics and ENT? And
I will work with anybody, but because my business has just been word of mouth, it's been oral surgery. I am working with a new client out of Alabama who does a lot of cosmetic surgery, full body cosmetic, as well as oral surgery.
because that's the standard in that world, right? They have a couple different accreditation bodies. There's AAAHC and like Quad stuff.
Quad A and Joint Commission has an office-based accreditation also now.
So there's 3 big ones in America.
Mhm. Yeah.
And in plastic surgery world, everybody is accredited. Is that wrong? Or is that right?
They should be if there's a couple of different pathways you can do. You can do the office-based surgery, which is what I helped your practice with. And then there's also the ASC route where you go the Medicare deemed survey, which gets into life safety codes and it's kind of higher level. So I primarily work with office-based surgery. So it depends on if they're working with insurance companies, if they're working with, you want to get reimbursed, if they're seeing Medicaid, Medicare patients, and they want to get reimbursed facility fees, then they typically would go the ASC route. But then also depends on if your state has a certificate of need to be able to establish a new ambulatory surgery center. So this gets complicated when you get into that route.
Yeah, Angie, you're jumping on the deep end all of a sudden on complexity. Wasson's we've lost. He's logged off. He started hearing certificate of need. Some in terms of AAAHC certification, there's different reasons why people do it, right? I mean, one of those which I was most interested in on my side had to do more safety, to be on the same par with, like a surgical center type.
Right.
The other ones to be able to hit the regulatory criteria so that you could create a tax ID and bill as your own facility. And that's a different pathway. Like AAAHC isn't just one pathway. There's different pathways depending.
Right.
That I was unaware of that, by the way. I don't know.
Yes.
I now know that, but Wasson, you have any of this at your facility, or are you thinking about it, or where are you at?
No, it's definitely on my radar. I think you and I mentioned it even here on the podcast. I was in the infancy of exploring this even in my Seattle practice of taking over some additional space and building out 1 or 2 ORs or a recovery area and getting it AAAHC certified. So I went through some infancy of the process at one point in time, and I think we'll get there eventually. But that's why I'm so glad that Angie's here to help us, because you mentioned those 2 pathways, and what would the specific criteria be for someone who's trying to make that decision? Is it essentially I want to be able to create, like I want to just have a safety profile to be able to show that I have a certain standard of safety compared to every other physical location where the patient could undergo a surgical procedure? Or do I want that in addition to that, I want to also create an entity for tax or billing purposes that I can bill facility fees? And you have to you reach a fork in the road where you have to choose one of those pathways. Is that what I'm hearing you guys say?
Yes, and really depends on the state and how much bargaining power you have with your insurance companies. There are some practices that are able to negotiate bundled rates with facility fees just with the office-based surgery, but not every practice is able to do that. Not every state will allow that. So when I talk with people about it, that's one of the things that I talk about is, if your sole reason of getting accredited is to be able to bill insurance companies, then I don't recommend doing that unless you can go the ASC route. But then you're competing with hospitals and freestanding ASCs in your area too. And then it becomes is it going to be cost effective to do that when you have all this other competition going on for that?
Yeah, that was kind of the conclusion I came to years ago in Seattle, was that volume wise, to create an ambulatory surgery center, you would need more than one surgeon in oral and maxillofacial surgery, especially with the volume that I was doing at that time. is you would almost have to build an entity and then recruit other people to use your entity to almost even break even. Now that was for an ambulatory surgery center capacity. Is that different if you're just doing AAAHC and creating an entity to bill facility services? Or those, am I confused in how I'm lumping those things or separating those things?
So typically, to be able to bill facility fees, you do have to go that ASC route.
Okay.
Like I said, some
Right.
practices have been able to negotiate that with their insurance companies, but that is totally up to their state and whatever relationship they have with their insurance companies. So
So then why am I doing this? Like, who cares? Let me just be the jaded cynic here. Like, why even go through this? Is it just to pat yourself on the back and say, hey, look, I've met certain safety criteria and look at me?
it's good for your patients to see. And every once in a while, unfortunately, you have an adverse event in a dental office that gets national or at least local press. And you have patients that come in and they're freaked out because all of a sudden they've heard of a death that was in a dental office in Texas or wherever. So when that would happen, when I was in the clinical side, I was able to say, in this practice, we electively choose to be accredited. That means we meet a higher standard of care than OSHA requires, the CDC requires, than your dental board requires, then it sets us apart to meet. It's confirming objectively that you are meeting a standard of care that is higher than most other practices do.
Yeah,
So
because what's strange about our specialty is with oral surgery, you can do a lot of surgeries in your office, right? Like we're just accustomed to doing anesthesia and surgery in your office. And there's already, a regulation on our specialty about that, right? We have in-office anesthesia evals, we have to meet licensing criteria for those sort of things. And so for me, at least, what helped out is those are still, there's a big leap from that to AAAHC certification. So I did the office-based surgery route with the anticipation of, for me, it was needed to work with different anesthesiologists, but it was likely, I knew of the pathway where it would be needed to negotiate with insurances in terms of having two different payer structures where you have professional fees, facility, and professional fees, non-facility. Those terms they're the opposite of what it means depending on the facility, right? You know that one, right, Wasson?
I'm not sure I follow what you're saying there.
Like your facility professional fees are lower because it was when you're doing the professional service at a facility that's a network versus facility fee is the one that you do in your office. Anyway, I'm getting off I'm sidetracked. But the blind spots that you have in your office, right? Because you don't manage everything, and just having things on paper and protocols and backup electricity and backup suction and just everything that you take for granted when you go to the hospital, just all the facility stuff that's there is why you do AAAHC. So if you're starting to do an office surgery, honestly, if it's like all on fours or TMJ care or any jaw surgery stuff, I mean, transitioning and doing stuff in the office, when you're responsible for everything, it's a different thing. And so you having the knowledge that, someone like Angie has helped you out, or, AAAHC has run through all that, is, for me at least, was really comforting. And it's almost like I don't want to see the bills just because, I'm paying for my own peace of mind when it comes to that stuff. But
I think another part of it is when you do start bringing in other providers, anesthesia providers, you go AAAHC required, or accreditation requires you to do a credentialing process just like they would do at a hospital. So you find out if they've had any, their National Practitioner Data Bank, which is every malpractice suit settlement is run through there. You find out if they've had anything. If you're just bringing somebody in because you know them from the hospital, you don't know the full history. You don't know if they have malpractice insurance. You find out those types of things when you're vetting people to bring in your practice when you're accredited.
Do you have to have that? Like, I guess maybe that takes us to a different area of discussion is like, what is required to get, I'm sure that's maybe beyond what we could even discuss here, is like I'm thinking in terms of chicken or the egg. Like, do you have to have an anesthesiologist? Like, if you're doing surgery, for the accreditation process, do you have to like have one or two or three that you're putting on your accreditation process as this is our anesthesiologist, here's their credentials, or is that the AAAHC process puts, as you're saying, the measures in place for every time you interview or talk to one, you vet them through a specified process as part of your accreditation and the NPD, as you said. How does that process work? Do you have to have all those ducks in a row to get your accreditation?
You do not. Well, if you're going to bring people in when you're accredited, you would have to have that process, but you don't have to have extra providers. They just go by the providers that are seeing patients in your office at the time you get accredited. So you would, if you were saying, all right, we have a CRNA that comes in, then we're going to have a credentialing process for the CRNA. If you have another oral surgeon that practices there, or prosthodontist or whatever, there's going to be a process in place to credential all of those providers that come into your practice.
Okay.
It's, I don't know what it also helped me with is just organize all the policies and procedures, right? Because you got all those for whatever history comes from your clinic and whatever consultancy you've had come through, just to get, kind of the medical and dental, and just be like, look, we're just going to run everything the same, right? Like we're just going to have the same criteria that we would have in ASC as how we take out wisdom teeth. And it was good for organization of the administration side of things.
Yes,
So-
I agree. And it really, their main focus is on patient safety. And so that encompasses everything that they look at is about patient safety. Again, going back to credentialing, making sure your providers are appropriately licensed, and you're doing that vetting of them, to the training process, making sure that your assistants that are coming in are appropriately trained before they're actually providing services or helping assist, making sure that, if they're starting IVs, that they've had the appropriate training for that. If they're taking x-rays, that they've had appropriate training for that. All of the things that go into training, it creates a process of an onboarding process, and then that ongoing training to make sure that your staff is appropriately trained for what they're doing for the patient safety aspect.
So every time someone with AAAHC accreditation hires someone new, in addition to just normal like hiring where you're validating their dental assistant license or their nursing license or whatever it is, you're doing additional stuff? Or is this, as maybe I think Sam you were trying to say, is it's not necessarily more, it's just a specific organizational structure that you kind of perform these actions within the confines of it? Or is it in fact just more work each time than if you didn't have it?
I don't mind if I take that.
Go right ahead. Sam is
Okay.
usually used to this
I'm not
anyways.
involved, so I don't
The
know.
way I like to do it with my clients is I create a customized onboarding list for them. So as you're training people, it's a lot of times it's documenting what's already being done, but it is not being documented, right? If you're going to train somebody in sterilization, you're going to train them in it, but you don't really document that. But with the checklist and what accreditation requires is that you do document it to make sure that they are appropriately trained. So if I'm training somebody in sterilization, I'm going to go through the process. I'm going to document it as I do it, and then I have a clinical competency that they pass, so that you can show that they know what they're doing. And if I'm the patient, I look at everything. If I'm the patient, I want to know that somebody knows how to sterilize instruments before they're sterilizing instruments, because if they miss something and they forget to start the autoclave and they don't realize that the indicator inside is supposed to change colors, if the instrument's been sterilized, I don't want those instruments used on me. So I look at everything, and when I train people, I train them in the mindset of everything you do, you need to do as if you are the patient or a family member is the patient. So that's why I like the AAAHC, because it's very patient-centered on patient safety, and I try to get people to think through every step you do if you or a family member was the patient. So you want to make sure that people are trained so that, like I said, with sterilization, with starting IVs, I've had people tell me that my doctor wanted me to start an IV. I've never even done it before, and he's just said, here, I'll show you how to do it. And they don't know anything about complications or anything. So it's just making sure that you have those checks in place. Like I said, the way I like to do it is I create a customized onboarding, and then at the end of each little section has that competency that they do. So it kind of flows. Once they get used to it, it flows with their onboarding process. It's just embedded in their training.
Because Wasson, I hear patient safety at the hospital, or like buzzwords that they throw out there, and compliance, and heaven forbid you're at the hospital when JACO comes by, because then they all start acting like how they're more interested in following policy than they are about patient safety. And I'm not hating on that, but there is a lot of that, honestly. I mean, it kind of leaves a bad taste in your mouth. I mean, for me, at least, it's kind of, I hear about new policy, and, I'm rolling with it, but, it's what I found nice about it is you can use those things to actually, improve your patient's care, right? Like, you can use it for the meaning of the words. And I don't know, I kind of, AAAHC didn't seem like it was a big penalty box, like it was adding a ton more work in my life. I do have a manager. She does manage all of that. So, that's important to know. But
that was going to be my question, is just a quick one, is you have a practice life in the same facility with and without this certification. Did this create more or less work for you? Did it make systems noticeably better, or is it harder to get buy-in from staff? Like, has there been turbulence? I'm sure getting the accreditation, the actual process is one thing that we can get into, but now just if I could show a pre-op, post-op, before and after image of your practice life with and without this, has it made things better? Has it made it worse? Has it been more work, less work?
For me, it's better. And it's largely because it compartmentalizes all of that into a thing that someone can manage, right? And then if like there's staff turnover, then you can plug people into that easier, right? And I know where to get that information. Ongoing certification, I mean, they check on you some amount of time, every 2 years or 5 years or something.
Every 3 years.
Every 3 years.
Who checks on you? You have to go through
Keep it going. Yeah. They come back and check on you, Wasson. I'm already checking on you more frequently than that, but it's good to have some other eyes on you. But that way, they recheck to make sure you're not forgetting things. Cause I mean, humans forget things, like we all do it. And so, I like that part. And it's stressful when you find something that you thought was getting done and it's not getting done. Right. And having a mechanism to keep an eye on that isn't you, for me, relieved a lot of stress. So I think that was probably a big change for me.
Yeah.
For me, there's some regulations that nobody has ever heard of until they go through accreditation. For example, if you are doing any type of medical laboratory tests, such as pregnancy tests or even testing blood glucose, you're supposed to have a CLIA waiver. That's the Clinical Laboratories Improvements Act. And nobody knows that until they go through accreditation. So you're supposed to be registered with the government, with your state, as being able to do CLIA waive test. And nobody knows that until they go through accreditation. There's just small examples, but there's some things that nobody knows about unless they go through this process.
The other one that I think you're asking about, Wasson, I mean, for me, it was like, do you set this up and then start practicing? Like, do you need to do this before you do any cases? And it seems like no one does that, right? Like everyone, I don't know.
Everyone starts doing cases and then gets it, right?
Yeah, they start on it and then you do it once you're running, which seems crazy. It's like building an airplane when you're flying it. But that's how it's done, right? Like that's how it is with all the other licensing pathways. Is that right, Angie?
Well, don't you have to have actual cases to show, like during the accreditation process, or can you have like not done a case and they just show up and accredit you?
So you can do if you're building a practice, you can do an early request for an early certification or early accreditation within the first 6 months of your practice. But if you do anesthesia or if you do surgery, they do want to observe a case so they can check out, make sure you've done all the checks and balances.
You probably want to have a few dry runs before you have an inspector.
Yeah, they're doing your first
absolutely.
case.
Absolutely, yes.
So I mean, you almost can't do it. I mean, that was one of the questions on my mind, Angie, and Sam, I guess you can weigh in if you want to be a little less useless than normal, is like with that in mind, it seems like the ideal scenario would be what you just described, in that, hey, I'm building a practice or I'm building an office. From the beginning, let's build and structure this in a way that has the physical requirements for AAAHC. Because if I remember correctly, and this could be incorrect, I think I got like a AAAHC manual, but it was, at this point close to a decade ago, or it could have been something for the ASC route. But I mean, there are actual physical in-office building requirements. Like it was, I think, one or more direct temperature controls for each room. You had to have like certain ventilation requirements. Sam, you mentioned like backup power, backup suction. If someone is thinking about going through this process and, may have to get a contractor involved or an equipment rep involved, like what kind of things would they need to be aware of, either for an initial build out or to add on to their existing office? Like what would they maybe not be thinking as far as what would be needed?
So that's going to depend on if you want to do the office-based accreditation or if you want to do the Medicare status ASC route. The Medicare status does have those requirements about fire rated doors and width of corridors and that type of thing. The office-based surgery is the size of the room appropriate for the procedures you're doing in there? Do you have appropriate backup power for the procedures you're doing? So if you're not doing full-blown general anesthesia cases where you're running, an anesthesia machine and all that, then your backup suction could be a manual hand pump suction, and a flashlight could be the backup light source. Because that's going to get you through the case if the power goes out. If you're doing full-blown general anesthesia cases, they do want to see that you have some type of backup generator or battery pack or something to keep that anesthesia machine going so that it doesn't crash and then you're manually bagging a patient till the power comes back on. Who knows how long that's going to be. So that's another reason why I like AAAHC is it's very reasonable. And as long as, they leave it gets a little bit confusing when you're trying to interpret the standards because they are vague, but that vagueness gives you the ability to pretty much make it fit into your own current practice. Does that make sense?
Yep.
Yeah.
It does.
Yeah.
That helps, because I think part of the hesitancy why people don't go through with this is possibly the overwhelming. It's seemingly overwhelming to go through, and like it's a lot to undertake on your own, and maybe that's where your business would come in, or others like it, to help with some of that handholding, because we all have practices, we all have staff, we all have lives, and I think that does seem overwhelming. Can you walk us through maybe some overview type things if someone was wanting to overtake this? Like what type of time frame should they expect? What type of expenses should they expect? What are frequent things that you see that maybe people don't realize until they get in the thick of it that they could undertake up front or be aware of up front?
So what I find, I'll speak for what I do as a consultant, is I typically like to come on site first, because I typically find that there's just some basic OSHA stuff that kind of stuff that we need to work on, just the clinical, kind of the clinical documentation of, are they documenting every time they run the autoclave, that type of thing, that they're doing the task, they're just not documenting it. So I like to come on site first. And then it really depends on where we're the starting point, on whether we can get it done in 6 months or typically 9 to 12 months. It just depends on kind of where we're starting. And when I always talk to the surgeons, the owners of the practice, I typically will start the conversation with, this is not something that you have a 30-minute surgery that's canceled, that somebody can jump in and start working on. I've got 30 minutes, I'm going to work on AAAHC. It takes dedicated time, and typically you don't have an extra person that's just standing around with half days and full days where they can jump into this, which is where it helps to have somebody like me to come in and meet with the practice and then customize the policies that are already there, that already have templates, to customize them to your practice. because otherwise people are they're staying late, they're doing on the weekends, then you start burning people out. And like I said, the standards are vague enough to make them really confusing if you don't really have experience with it to try to figure out what they're trying to say. So it takes a lot of dedicated time. I don't think it takes a lot as far as like cost associated with all the stuff that you need. I mean, typically they already have sterilization pouches and they may have to order the little internal indicators. I don't think there's too much cost as far as the maintenance of it. But I just think it's hard. And I say that from my experience because we already had full-time jobs and they said, let's get accredited. And it did take a lot of time away from patient care, nights and weekends for me to get my part done. So that's what my experience has been.
Sure.
Yeah, Wasson, I tried, this sounds silly. My mother-in-law was like, really, she got excited about helping out the practice in some way. And so I was like, why don't you just look at this AAAHC thing? I think it's pretty straightforward. And we signed up for it, and it was ridiculous. I took her off the task early on when it came to this stuff. So it is a lot. I think assigning it to one of your crew is a big ask. So for me, like getting the consultant was helpful. With jaw surgery, people like knowing how much stuff's going to be before they go sign up for jaw surgery, right? Like, is it going to be 10 grand? Is it going to be 20 grand? What's getting AAAHC certified for, let's say, in-office or office-based surgery versus like ASC? What do those things run?
So it depends on the size of your practice, how many providers you have, but they typically, the practices that I help are 1 or 2 doctors in one location, and that's around 8,000 or 9,000 for the accreditation survey. There's about $1,000 application fee, and then it runs about 8,000 to 9,000 for the actual survey.
So $10K for just the AAAHC checks.
Process.
That gives you 3 years and just kind of like that step. And then consultants need to help you with that because then it's more.
Yes.
And that is 1-2 times more. What are we talking?
It varies. I think from some AI research, I'm on the low end. But it's about probably twice that, 2 to 3 times, depending on who you go with. Yes.
Got it.
Yeah.
In addition, so like you're talking 20 to 30K for consultant fees or 20 to 30K total?
Total.
Okay.
Yeah.
Yeah, because I think that's 20 or 30 plus 10. That's what I just heard. Do we hear it wrong?
It would be approximately 10,000 for the AAAHC expenses, and then and 2 to 3 times that for the consultant fee.
Got it.
Yeah.
So total, we're looking at probably 30 to 40K.
Yeah.
Okay, so if we need to put money aside or we're asking for a practice loan, budgets 30 to 40K. Okay.
Yeah.
I mean, that's not unreasonable. I think we all want to be compensated for our time. And if you're taking a significant burden off of somebody as a consultant, I mean,
because
like
otherwise you end up paying that out in overtime or staff burnout where they just don't want to do it anymore.
Yeah, I mean, that was going to be one of my questions for both of you, I guess, again, is how do staff typically respond to this? Because even if you coming in as a consultant, Angie, I would imagine that it's changing a lot of processes, a lot of systems. Is there turbulence? Is there resistance to this? Or do they typically see the value in it and go, okay, this is not a big deal. I don't have to really change what I'm doing as much. Maybe I'm just documenting it a different way, as you've said a couple times. Is that what usually goes down, or is it all out brawls with you when you come in and try to teach them to do stuff?
I think it depends on the starting point. I've had practices that they were documenting more than they should, and so it didn't make that much of a difference. But what I typically tell people is, look, it's going to seem like more work, mainly on your clinical team, because it's mainly focused on the clinical aspect. It's going to feel like more work. Once they get into the routine of doing it every day, then it just becomes habit. And when you bring new people in, then it's just part of their training. It's just how we do things from day one. So I think for the current people, I would say it feels like a little bit more work. But I try to embed things in as much as like an opening checklist. So, they're just doing it as part of their getting the day ready for surgery when they're making sure that documenting that they've checked the refrigerator temperature and the humidity levels, that type of thing. So I just try to make it part of their morning routine and then close it out at the end of the day and try to handle it from that aspect.
Sam, did you have it that way, or was there problems, issues, or did they?
I forgot how the timing went in my office. There was what year you probably don't have any better memory of this than I do, Angie. Sorry. I was gonna ballpark, this is a couple years ago. So from our side of things, it seemed to help organize it all, honestly. So like it was easier bringing new people on, especially with people with medical background, because it was all familiar things, right? Like they're kind of used to having those sort of setups. And I also get people from dental offices, right? Like you hire a dental assistant or oral surgery assistant from a different office, and getting those guys kind of more standardized onboarding and just understanding the processes associated with how you do things. I just kind of liked it better because honestly, where did yours come from, right? Like when you started your practice in Seattle, where did your policies come from? They would have came like from some Amos handbook, or you had a practice consultant give you the information. And where did they get the info from? You know what I mean? Like it was nice to have, because my background is I didn't steal, but I used a lot of Swedish stuff, which is the hospital that my practice is spun off from. But a lot of their stuff was really generic, and it was very much like on the, yes, it's true for all surgeries, but is it necessarily true for oral surgery type things, right? Mm-hmm. And so it kind of helped our assistants and managers more than it made their lives terrible.
Okay. So Angie, when you go through this process with a number of offices, as you do as a consultant, where do you recommend people start? So like if they're considering this process, do you recommend, if I'm remembering correctly, like you could buy a AAAHC handbook or whatever for like $100 or something. Do you recommend they start there and like skim it to make sure it's something they want to go through? Do you recommend that they speak to someone like you, but not your competitors, of course, if you have them, but speak to someone like you to kind of have a preliminary talk to help guide them if it's something they want to undertake? Like, knowing what you know now, someone like me, if I said, hey, I'm really interested in pursuing this, where should I start? Where would you recommend they start?
I would recommend reaching out to your colleagues and see if they are accredited, to find out their perspective from the process, talk to their office manager or whoever was the point person. I have a new client that bought a software package, and they were doing triple the work that they needed to because they just didn't know what they were just following everything the software said to do. And they were double documenting things. They were documenting on a paper log and then putting everything into the computer system. And so they were actually doing a lot more work than is required, but they just didn't know that because they don't know what they don't know. So I think that's where it does come in handy to have somebody like me or a consultant because what I try to do is I take everything that AAAHC says requires documentation or in writing, and I turn that into policies. I combine as much as I can so you don't have a separate policy for every single standard, but I try to combine as much to reduce the amount of paperwork and updating policies that I can. But to try to read the standards, it is really confusing. They're really vague, and to try to figure out like, how do we meet this standard that says, appropriate referrals are made? What does that mean? Medication reconciliation is done. What does that mean? It's just trying to figure all that out can be a little bit overwhelming.
Okay, that makes sense.
Yeah.
Go ahead.
Can I ask, on the other ones like the JACO and the other, why are there different organizations? Are they can't settle on just one way to do it? Like, what do they got?
Well, I think AAAHC came about because Joint Commission was a lot more of the white glove test, more on the facility side. AAAHC came in, and they don't do hospitals. They do office-based surgery. They do healthcare HMOs. They do dental offices, medical offices, And they differentiate themselves because they focus on the patient side more than the facilities. It's all about patient safety.
Got it.
And then the other
then-
one, the SF or the A's, or the other one that I see plastic surgeons use, is that just a newer one?
I'm not familiar with that one, but there's Quad A, but I think it's just, there's just different, different.
It's
I
Okay.
imagine there's similar standards. So,
Yeah.
Yeah.
And then I guess my follow-up question to some of these would be, is there 1, 2, 3 or more consistent or frequent roadblocks or barriers that you see? Like, oh man, in every office, once we get past this reality, it seems to go smoother, or this is the most frequent thing I see misinterpreted when people are trying to do this, or are there certain things that you see consistently that people should be aware of going through this process?
Basically, like I said, it's getting everything in writing in an organized manner, because people are typically doing things. They just don't know how to put it into a policy that works for them. And then the documentation of training. And honestly, when I go into oral surgery practices, and this may be in other specialties too, but we just have a habit of not wanting to let go of expired things. Like this thing we ordered and it's like 10 years old, but I don't want to let it go. And that's one thing that is a requirement. So, we try to, so there's that. And there's like single-use medication vials or multi-dose vials. I mean, they hang on to stuff longer than they should, and pre-drawing their medicines, their IV medicines, days in advance. That's an infection risk, infection that people still do. And it's a little bit of everything. But those are the consistent things I see. Documenting the allergies and what the reaction to allergies is, not just the allergy. Probably the biggest thing I see is, as far as patient safety, is doing your pre-surgery verification, where you're confirming with the patient what procedure you're doing on that patient. And then you do your timeout with the entire surgical team. And that's where, that's going to prevent your wrong tooth extractions. And, they came in for the consult for wisdom teeth. So everything was done, the treatment plan, everything was done for that. They're on the schedule for that. They walk in the day of surgery. They can only afford to do the one that's bothering them. And that somehow doesn't get communicated because we don't do our procedure verification. We just go by the treatment plan for the consult. And then all of a sudden you've taken out 3 extra wisdom teeth. No harm, but you ended up not charging them for it because that's not what they came in for and that's not what they could pay for. So those are the kind of things for me that kind of get rolled into the patient safety umbrella. But having those processes in place through AAAHC is life-saving to me. It's just all those checks and balances for your benefit, and by far and large, for the patient's benefit, but also for your benefit. I don't know. I've been in on a wrong tooth extraction. It's not a fun place to be. So if I can do whatever I can to help prevent that, then I'm going to do that. So.
Yeah. I mean, the scary malpractice stuff and the legal aspect of things never really motivated me on this stuff. It was more like, man, it's crazy. We don't just do this anyway, right?
Mm-hmm.
Like we're doing surgery on people, taking out wisdom teeth or implants. And certainly, even like genioplasties or hardware removal or domes or midline distraction or, whatever, TMJ arthroscopy, whatever you're doing in the office. And we don't have that lined up, right? Like that doesn't seem right. So it just is kind of like, hey, like you were saying, like if I'm going through a surgery, my family's going through it, I just want to have all the check boxes done, right? So that, you can feel the facility.
You do have to still do it. Like, I mean, having an accreditation and not doing it is no safer than.
That's what the reaccreditation is nice about. I mean, I haven't gone through that yet, but I assume that's what the nice part is that they can check on it. Cause it's like anything, you have meetings and you talk about it and you're like, hey, let's see where we're at with these things. Like there's ongoing trials or studies you run in your office, like infections or quality study, having people whose part of their job title is to do that. I don't know. People seem to like that stuff. It's like the safety officer.
Yeah.
And what I'm trying to do, talking about quality studies, because you do have to have quality improvement studies. They want to make sure that your goal is to continuously be improving your organization. And so what I'm trying to do, because my clients are oral surgery, is there's just not a lot of good data out there specific to external benchmarking for oral surgery. So I'm going to take my clients and encourage them to participate in, let's do an implant failure study and let's figure out which systems are, and you can get some of that externally, but it's not readily available. It's kind of hard to track down, but let's look at infection rates. Cause I think when we did yours, Dr. Bobek, we pulled from clean, sterile cases, but that could be anything. That's not just specific to oral surgery. So I'm trying to get, bring some more value to you by saying, let's do quality studies on infection rates specific to oral surgery and not just, for all types of oral surgery, and de-identify everybody else's, but you'll have your rate compared with a bunch of other oral surgery practices instead of just pulling data from
I remember that.
wherever.
It was just like getting in the weeds, and that stuff is tricky because then, if you do double jaw chin, it's 4 incisions. So, if you have 1 of 4, did you have 1 infection or did you have 25% infection? You know what I mean? Is it per patient? And then what's infection? What isn't it? You got to come up with definitions of these things.
Yeah.
Anyway, but it's good to kind of like have whatever you set on, right? Like it's just like any paper you're writing, like you got to come up with something, right? And so you defer to other people who have done this in the past. You look up the reasonable definitions for these things, the different types of surgeries, clean, contaminated, sterile, those sort of things have published rates generally with infections. And then, you follow it because it isn't like where you're at. That's important, but also like where you're going. And as long as you're getting better at it, I think it's good. But I mean, even something like that, honestly, we're all busy people, and kind of what we're doing is, we're not just twiddling our thumbs. Little old man, is that little old man saying?
Kind of. You could say dilly-dallying.
Dilly-dallying was in there too. So I would say that, you're busy otherwise. And so knowing that someone's working on some quality for the clinic is nice. So that's, it's largely helpful.
So Angie, are you, as a consultant, or not even you specifically, but any consultant or you specifically, both, are you involved in the reaccreditation process? So like, you help people get accredited, and then are you with them along their entire journey as long as they have that accreditation? Is that optional?
That is optional. Yeah, that is definitely optional. All of my clients, I think, except one that was in it for the insurance reimbursement, and they have realized that didn't work out, but all of my clients signed up for that 3-year maintenance so that I'm keeping up with all the stuff for them and working. Like I work with with Dr. Bobek's practice manager, and we meet on a regular basis to make sure that she doesn't have any questions, to make sure that they're kind of keeping up with all the tasks. Because there's so much work that goes into getting accredited. And then once it's done, it's like, whew, okay, now I can get back to my regular stuff. And then you realize that sometimes things can start slipping. His practice manager is fantastic. So every time I talk to her, she's like, yep, I'm doing the checklist. I'm following the calendar, making sure we're staying up on things. But when it comes back time to do quality studies and infection control risk assessments and all that, that's going to be nice to have me to help manage all of that.
I have one kind of last major question that I want to make sure I get to. So if you're involved in the initial accreditation process and you're frequently involved in maintaining accreditation, do you have offices that tell you, or does it come to your attention after the fact that either they go through the process and then later wish they hadn't, or they go through the process and then no longer seek out reaccreditation? Does that occur? Or do
it has not with my clients. It is not. I haven't had anybody that doesn't want to maintain it. I'm sure it does. I'm sure it has happened, but not with my clients. It hasn't.
Yeah, essentially what I'm trying to get to is what, from your perspective, what would be the circumstances or things that would occur that would make someone go, oh man, I don't want to do this anymore, or this wasn't worth it? Would it be solely kind of a change in practice philosophy where they're not doing much office-based surgery, so it's not worth it? Or are there things that you do see come up where people are like, oh, okay, I don't really need or want this. This was a waste of time?
Yeah. Like I said, for me, the one practice that may not choose to, really was hoping they would be able to negotiate with the insurance companies to get those facility fees, and they haven't been able to do that. So I don't know that they'll keep it up. If that was their main reason for doing it. So I don't know that they will, but other than that, it would have to be just a change in practice philosophy. I mean, to me, if you're seeking it out because and maybe somebody wants to do it just to make sure they're doing everything right, and then it doesn't really matter once they've gotten it to make sure they maintain it, or they feel like they can maintain all the quality of care without it. But I haven't run into anybody that doesn't want to maintain it.
Okay. That was really, I think you did a great job answering my questions. Sam, is there anything that, as someone who's gone through this and is in the ongoing process of it, that other, our listeners might not be aware of, or that would want to know, or that surprised you, or?
I think, what you were just talking about, I would find it hard to believe that you would just cross the finish line and that's it. I think that there is benefit of ongoing maintenance to make sure, because there's new rules and there's new stuff that comes up. But they do a formal person comes in and spends the day. And I want to say she might have even spent 2 days, like some crazy amount of time, like observes the surgery.
Usually a day and a half or 2 days, yeah.
Before and after. I think we did a scope or something like that, and just following up records. That wasn't as stressful as I thought it would be. I bet that would be way worse if you were doing it on your own, though. So I think putting the plug in for a consultant with that. But it was nice to have someone who goes to offices and does this as, like a retirement job, or, after their whatever reason, they're just focused on that. And they bring fresh eyes to make sure everything's in the up and up, because I don't know. I know we've talked about it. I think there's a lot of benefit of doing surgery in the office. I think if it's to improve patient outcomes, all this does is get you started in the right path. And so you can just keep improving from that point forward. So, I mean, Angie, I guess I've wondered this. How do other countries do this? Do they offer this sort of thing? I know obviously the world is big, but like Canada, let's say, or, let's throw Canada out there. Do you have any idea of how the crazy Canucks do this stuff? Do they disregard?
I don't know about Canada specifically, but I do know that AAAHC has an international accreditation.
Okay.
So they do go in different countries to do this. Yeah.
Right.
Yeah. Yeah. And for me, just to kind of wrap it up from my standpoint, I'm happy to answer any more questions, but you're asking earlier about the advantages to doing it. For me, the biggest advantages are, it just shows that, to me, it's saying you are focused on doing the right thing every single time, and that you're showing that you're committed to that. And it just creates a culture where your employees can be proud to work there, because they know. I mean, if you ever talk to nurses that come to oral surgery, it's like they know they're not supposed to be drawing up medicines 3 days, 4 days, 5 days in advance. They know that. And whenever they find out that now somebody's coming in and telling them you can't do that, it's almost like this relief of, okay, I knew we weren't doing things right, but they weren't going to be the new person that calls anybody out on it. So it gives your team a sense of pride to know that they're working for somebody that is committed to doing things. You do it right every single time. There's processes in place. It's easier to train people. It's easier to fall back on. We're doing this because we're required to, but also it's just the right thing to do.
Yeah, that makes sense. All right. You want to end it there, Sam? You got anything else?
No, I think that's it. No, Angie, I appreciate you coming on. I mean, if I was just talking about this with Wasson, I wouldn't be able to give 90% of the info you gave. Probably pretty close to 100%. It would be a lot of hand waving on my part. So I really appreciate you coming on. I mean, I know you've helped us out a lot, and you've helped out other people. And if your first clinic was getting Tucker and those guys up to snuff so they could do in-office JAWS, I mean, those guys have done in-office JAWS forever. So
yeah, since 1999.
You were there at the beginning, so it's kind of a cool life history. So appreciate you sharing that stuff with us.
Yeah, you're welcome. Happy
Awesome.
to.
Well, yeah. What was the name of your consulting company again, in case people want to reach out to you?
It's Murphy Healthcare Consultants, and I will probably have my website up and running by the end of the week. So
Okay. All right.
just now getting to that.
Angie used to run a real small business. So that's good.
Yes.
Well, thanks again for coming on. That was another Down Fracture podcast, a podcast for talking jaws, downfracturepodcast@gmail.com. And guess I'll see you next time, Sam. Thanks again, Angie.
You're welcome. Thank
Yeah.
you.
Take care. See you guys.